students, welcome to our dermatology class.
Today we are going to study sarcoidosis in dermatology classes. So first we have the outline of our today's lesson. So we will start with the definition, etiology, pathogenesis, risk factors, symptoms and diagnosis and treatment. So we'll start with the definitions. Definition: sarcoidosis is a multi-system disorder of unknown etiological characterized by non-satiating glandular in which affects the most common is lung and other organs are also affected. Sarcoidosis can affect variety of organs with varying frequencies, including our liver, skin, eye, liver, heart, neurovascular system and muscular system. So after the definition, we are going to go on the etiology. There are two types of our etiology. The possible etiological agent is our general and environmental agents. In our genetic association, we started polymorphism. We have HLA gene and HLA-DRB1. And in environmental agents, we have two, non-infectious and infectious agents. On the other hand, in the second, we have potential infectious agent, which are four. We have mycobacterium tuberculosis, human herpes virus 8, and propionibacterium acnes, and Borrelia burgdorferi. We'll start with our third slide in the pathogenesis. We'll start with the pathogenesis. We have antigens, I have said earlier, HHV, P. acnes, and tuberculosis, mycobacterium tuberculosis, which is a bacteria. When they get exposed in our body, macrophages and our dendritic cells, they start the phagocytosis process. After the phagocytosis, they take inside and go for the phagosomes. Phagosomes will go after with lysosome and phagosomes. They will form the phagolysosomes. After the phagolysosomes, we have in phagolysosomes there is a nucleus in which we have HLA on the 6th chromosome, which will go for polymorphism and release HLA-DRB1, and MSC2 complex goes to the lymph node, any lymph node in our body, and there are two macrophages and T cells play a role in our lymph node. By macrophages releases our cytokine IL-1, and innate T cells in turn release IL-2, which is also known as autocrine. In autocrine, IL-2 releases, there is T cell proliferation. In T cell proliferation, Th1 is releases. After T cell proliferation, it leaves the lymph node. While leaving the lymph node, IF and gamma is increased, and it will go to the macrophages, positive macrophages, and we will have these three: epithelioid cells, special epithelioid cells, lymph node, macrophages, and fibroblast. These four of them, they go for the aggregation. In aggregation, they will form the macrophages coliasis. In macrophages coliasis, we can see this is a multinucleated glial cells, and we have two types of bodies present in this, and squamous bodies and asteroid bodies. Asteroid body is said because they have a star-like structure, that's why they are called asteroid bodies, which further go and form a beautiful body. As we can see here, they are in the organ, on the outer side we have fibroblast, and fibroblast and lymphocytes are connected by our fibrous tissue. They form a connective tissue, and then they form the non-caseating granules. This is the name is given because there is no tissue necrosis, and in this also we can see the squamous bodies and asteroid bodies. While anyone can develop sarcoidosis, but there are some risk factors: age and sex, family, and race. So we'll start with age and sex. Sarcoidosis can occur at any age, but often between the ages of 20 to 60. Women are actually more likely to develop this disease. In the race, the American Africans are more involved. People of African descent and those of Northern European descent have higher incidence of sarcoidosis. In family history, if someone in your family has sarcoidosis, and you are more likely to develop this disease.
I discuss about the impact of the sarcoidosis of skin. At first, the sarcoidosis of skin is divided into three types. At first is a lupus perineum and skin lesion and erythema nodosum. Erythema nodosum is a suddenly red color, and it's a painful limbs is present in mainly effect on the leg and hand. Next, we come to the lupus perinatum. Lupus perinatum is a blue and red white color. It's a mainly skin and painful skin and is a superficial lesion. And next is a skin lesion. Skin lesion is a brownish, bluish color and the pinkish color, and it affected the very painful on skin, and it's the superficial structure of the skin, and it's mainly occurs with the fevers and irritating, swelling, everything. Now I discuss about the symptom of the skin. It can define or examine many ways. At first, the ways is the discoloration of the skin. Discoloration of the skin, pigmentation also loss, and the rise of the skin and the papules are the present more than the 3 nanometers, and also rise the skin papules is the smooth and the rough skin color, red and the brown eyes. And next PPT is the where does the sarcoidosis appears on the skin. It appears mainly the neck, head, scalp, and hand, legs, buttocks. You can see this picture. This picture have a bumps like small bumps like and bored and the rise on skin. It's a discoloration also and pinkish and brownish color present. You can see also when it's a long term, it's a long starting and discoloration of the scarring. This scarring is also present. Guys, you can see those picture. That first picture is a red brown on pacule on the nose, and also same nose of the nodule, and nodule is present. This is the granuloma, naked granuloma present. When we see the history of the nose, that the history of the nose is the naked granuloma present. This naked granuloma is divided into 2 types. That's the A and A is the 30% affected, and ACE or the 50% is the affected. And next is the nodule like the nose is seen that it is the naked tuberculosis. And naked tuberculosis when is the present is the solid nodule present, and you can see the both those picture. At first picture is the lacus perneum, and second picture is the patient with febrile with the papules on the both skin. When the lupus perneum, that's the lupus perneum is also seen in the nose and cheek. It's mainly position and the affected of the site. It's affected by the lungs and the URTS. It's the lungs is the 75% and the URTS is the 50%. And the febrile with the papules on the both skin. The papules is the mainly you seen in the fever, and the symptom is the fever, sarcoidosis, and the EN. When we see the chest X-ray, you see the healer on the chest X-ray. Atherosclerosis also see that, and the blurry vision also seen in this. Blurry vision and 7 nerve palsy seen in this. The febrile with the papules and the naked granuloma also seen in the history. I also explain this. The small bumps is present and rise passes is present. Small bumps look like this. This is the small nodules legs and the with the solid structure, and the rise passes on the cheeks, the rise passes on the hands. And next is the discoloration of the skin. I will also explain this. The discoloration of the skin, that's the pigmentation is lost both face and the neck. And next is a skin of the right of the passes and the hand. Next is the discoloration of the fingers, rise passes on the head, and right passes on the buttocks. And the next 2 picture. At first picture is a scleroid mimic a scleroid on the pemic earlobe. And second is you can see the papules curled on the dorsal on the hand is the affected on the most in the sarcoidosis in picture.
Now we will discuss about the treatments and most probably when to treat. Starting with the pulmonary disease. First of all, let me make it clear, it is an associated disorder, it is not the main disorder. Now let's discuss. As you can see, stage 1 disease. If the patient possesses erythematodeum without extra pulp, this is the very mild sort of the situation which if left untreated doesn't harm the patient much. Now stage 2 disease without symptoms and mild functional lung impairments. This stage should be treated. Stage number 3, disease with or without symptoms should be treated, and stage 4, disease, respond poorly or not at all to corticosteroids immunosuppressive therapy. This is a life-threatening condition and should be taken care in the emergency unit. Now we'll discuss about the choice of drugs. The first category of drug is corticosteroids. The mechanism of action of corticosteroids is that they act by gene transcription, leading to the inactivation of nuclear factor kappa B. Here we need to focus upon the nuclear factor responsible for the disease, which is kappa B. The example is prednisolone 440 mg daily maximum dose. For 3 to 6 months, 4 times daily it should be given to the patient. Now we have the alternative drugs, starting with the cytotoxic drugs. Rationally, use of cytotoxic drugs with low doses of corticosteroids given with the corticosteroids enhances its efficiency and reduce the toxicity of the disease. Methotrexate, it is a common example of an immunosuppressant. This is preferred second line of drug, 10 to 15 mg once a week given, often with the combination of corticosteroids. Others are azathioprine, it is another common example of immunosuppressant. An additional information to this is these all are systemic drugs. We have one topical drugs named hydroxychloroquine. This is a tube available in the market which you can directly apply on the skin lesions. Hope this video helps you with the exams. Thank you.